my name is Jordi Guimerà. I'm a urologist in Son Espases University Hospital in the urolithiasis unit. It's a hospital that is placed in Mallorca, Spain. And we are going to talk about the distal tubular renal acidosis. It's I think, a tough topic to talk to the urologist, but I'm going to try to speak it explain it easily. Well, the main issue with the distal tubular renal acidosis is that the kidney has a decreased secretion of acid into the urine. And we have two forms, complete and incomplete. So the complete form is a very severe disease that is mainly expressed in childs and is associated with a short life expectancy. So for us, it's not important and is rare. It's a rare disease. So for us, the important thing is the incomplete type of distal acidosis. That is the one that is expressed in adults. So if we were talking about complete, we were saying that we have a patient with metabolic acidosis, but in the incomplete form, we don't have metabolic acidosis. The only thing that we have is alkaline urine, because the kidney is able to secrete a little bit, do a little bit of secretion of acid, but not enough to evacuate or to do the secretion of all the acid in the body that is needed. So the body starts to do bone resorption and release calcium to do the buffering effect. So we have alkaline urine with a pH above 6 and hypercalciuria. So here is another slide. I think is easier to understand. Here you have the complete, all the patients, all the spectrum of the patients with distal acidosis, and you have the complete way is the small number of patients, and you have metabolic acidosis, and then you have a very wide range of clinical expression in the incomplete form. So you can have patients with incomplete form, very severe, close to the complete form, and you have patients with the incomplete form that they are like a healthy person without almost any problem with the kidney stones. So if we have alkaline urine and hypercalciuria, we are going to have two types of stone, the calcium phosphate stones and calcium oxalate dehydrate. So if we have a patient with calcium oxalate monohydrate or uric acid stone, they are not going to have distal acidosis for sure. We need that the patient have calcium phosphate stones or calcium oxalate dehydrate. So we are talking about this illness, but we have to know if it's important or not, because if it's a rare disease, there is no need to talk about that. Maybe it's more important to talk about idiopathic hypercalciuria, I don't know. But it's important. So almost 50% of the patients with alkaline urine and hypercalciuria, they have distal tubular renal acidosis. This is a lot of patients, and this illness is not a hot topic in neurology. I don't know why, but there are so many patients with this illness. So, well, we have now the suspicious. We have a patient with alkaline urine and hypercalciuria and an appetite stone that was removed by ureteroscopy 1 year ago, for example, and we want to know if he has the illness or not. So we have two tests for the diagnosis. The furosemide with or without, I don't use it, but theoretically it has to be used, fludrocortisone, and the acid overload test. So in my opinion, the acid overload test is the gold standard by large, but it has a high rate of side effects and dropouts. So, and it's a little bit complex to perform. In my hospital, I perform the furosemide test without fludrocortisone in selected patients. It's easy to perform, and I think if you use it correctly in the correct patients, is equivalent to the gold standard. Here is a simplified slide about the test. So you make the patients to you have a urine sample of the patient before the test, and you have to measure the pH. If the pH is above 6, you continue the test, and you give him furosemide 40 milligrams. And then you have to measure the urinary pH the 3 hours after the furosemide take. So in all the urinary pH, in the 3 hours after the furosemide, the pH is above 6, the patient has tubular acidosis. If not, it's negative. You can simplify that because most of the patients can do maybe 5, 6, 7 urination, and it's difficult to a laboratory to do all that test. But you can simplify that in every hour. So in the first hour, when you have 1 hour after the furosemide, do the urinary pH, then the second hour, and then the third hour. So it's only 3 samples of urine to analyze. The treatment. There is no standard treatment for the distal tubular acidosis, and there is less standard treatment in the incomplete form. Well, we have 3 ways to treat this illness. One way is doing alkalinization with a classic way with potassium citrate, and with a new treatment that was developed in France and is called Sibnayal. And to inhibit bone resorption, that we have so that is very important because that's the reason why we have hypercalciuria in the urine, and the reduction of the calciuria using diuretics. So the management, that's the things that my practice in my hospital. The first step, I use lead control pH balance, 1 tablet every 12 hours, because it has a very good dose of phytate and also has magnesium. And sometimes if the calciuria I saw it's very intense, about above 300 or 350, I use indapamide. And then in 3 months, if this calciuria is not controlled, I add to this treatment or Sibnayal or potassium citrate. If I'm lucky and my hospital pays for that, I use Sibnayal. In my opinion, is better than potassium citrate alone. But it's an expensive treatment and is not covered in all the, well, in Spain it's not covered by the public health. So the follow-up. The follow-up can be done, or well, I do the follow-up with beta-cross labs. I use beta-cross labs like a bone resorption maker. I use the cut point of 0.4, and if the patient in the follow-up in the 3 months after we initiate the treatment, they have beta-cross lab under 0.4, for me is well controlled. Also the calciuria. In ideal, well, very strong cases, it's difficult to put the level of calciuria under 300, but it can be possible. And if you have the patient under 200, it's fantastic. Then you can perform annually a CT scan to check what's going on with the stones, and bone densitometry. I perform the bone densitometry just after the furosemide test, if I have a positive result, and then 2 years after the treatment. There are a lot of patients with under 30, 40 years old that they have osteopenia in the bone densitometry. Is not, you think that is not going to be usual, but it's usual, they have it. And in conclusion, for me, this illness, the distal renal tubular acidosis, is underdiagnosed. Furosemide test is equivalent to the gold standard in selected patients, and phytate, for me, is the main treatment, well, almost for all stones, but for this, for me, is the main treatment and is effective and safe. Thank you.